أسعد الله مساءكم جميعا. My presentation today is going to be about bariatric surgery. We will have a quick review of a bariatric surgery with a particular concentration on the question, is gastric bypass a cure for type 2 diabetes? Okay, bariatric is derived from the two Greek words, paro meaning weight and iatrek meaning treatment. So it is the treatment of overweight. The recent tremendous increase in the number of bariatric procedures worldwide are fueled by two things. First, the advance in the laparoscopic technique, and second, the overwhelmingly increase in the obesity epidemic. In the United States only, 65% of the population are overweight, 35% are obese, 5% of which are morbidly obese. This causes almost 400,000 deaths annually, costing almost $200 billion annually. The epidemic is ever expanding, and it is not confined to the United States, it's worldwide. Now, the history of bariatric surgery did not start yesterday. It started in 1954, but the recent development is fueled by what I have already mentioned. Okay, the first procedure, let's go back. There are many procedures which appeared in the last 70 years, and there are many procedures which disappeared. The plethora of all these procedures mean that we do not still have the perfect bariatric procedure. The bariatric community believes that gastric bypass, by outstanding the test of time, is the perfect bariatric procedure. It is the gold standard as considered. Now, bariatric surgery started in 1954 by Kremen, who introduced the jejunal-ileal bypass. His procedure consisted of joining the proximal jejunum to the distal ileum. As expected, all patients had significant loss of weight, but they also had significant protein malnutrition, vitamin deficiencies, and steatorrhea. What was unexpectedly high was the irreversible liver cirrhosis. This was caused by the defunctionalized small intestine. Now, in the 1980s, after doing thousands of this procedure, the recommendation was any patient who has this procedure is to be reversed to the previous position. And this procedure has fallen out. Scopinaro, in trying to overcome the problems of the jejunal-ileal bypass, introduced in 1978 his biliopancreatic diversion. He did a hemigastrectomy as the restrictive part of the procedure, and he reshaped the small intestine in a form in which he anastomosed the biliary limb 70 centimeters from the terminal ileum. The Scopinaro procedure did not have liver cirrhosis as a complication, but still a high percentage of patients having protein malnutrition and steatorrhea. Because of the shape of the anastomosis between the stomach and the small intestine, large percentage of these patients had hypoglycemia, had dumping syndrome, and stomal ulcers. To overcome the problem of the hypoglycemia and the dumping syndrome and the stomal ulcers, His introduced his his duodenal switch as a modification of the Scopinaro technique. He did a sleeve gastrectomy, and he anastomosed the first part of the duodenum to the distal alimentary limb. Not the biliopancreatic limb, but the alimentary limb. This procedure also had a large percentage of protein energy malnutrition. Mason is considered to be the father of bariatric surgery. In 1967, he noticed that people who underwent hemigastrectomy for peptic ulcer disease failed to regain weight. So he suggested doing Billroth II gastrectomy to obese patients, to morbidly obese patients. Later, he abandoned the idea of doing a gastrectomy because of the high morbidity, and because of the introduction of the staplers, he did partitioning of the stomach. Modifications of the Mason technique include a small gastric pouch, 30 cc gastric pouch, a small anastomosis between the gastric pouch and the alimentary limb, and an alimentary limb of about 100 to 150 centimeters. This is the classical gastric, Roux-en-Y gastric bypass that we do today. It has been in market since 1968. This is the procedure which had already stood the test of time, and it was one of the most commonly performed procedures in the United States for the last 40 years. Now, also Mason suggested, because of the problems of anastomotic widening and pouch widening, he suggested putting a band around the lower end of the pouch. This band was initially polypropylene band, later elastic band, and later they suggested doing a band connected to a port in which you can change the size of the band. This has actually led to the lab band in 1993. The lap band procedure was one of the commonest procedures done in bariatric surgery between 2002 and 2008. We can say hundreds of thousands of laparoscopic adjustable bands have been performed during these years. It was the commonest bariatric procedure done worldwide apart from the United States during that period. I will summarize the fate of the band by saying that band surgery is vanishing. And I think the main reason for the vanishing band surgery is not the patient intolerance for the band and its complication, but rather the surgeon's intolerance for the banded patient. In 1995, Garnier suggested doing a sleeve gastrectomy as a bridge for patients before doing a gastric bypass. He suggested that doing a sleeve gastrectomy and reducing the weight initially would make the bypass easier and with less complications 1 year later. They discovered that almost 50% of the patients did not come back to the definitive surgery, meaning they had satisfactory weight loss. And since then, sleeve gastrectomy is considered a primary bariatric procedure. The statistics from the American Society of Metabolic and Bariatric Surgery between 2010 and 2020, you can see that the sleeve gastrectomy increased constantly from 2010 to 2013. In 2013 and 2014, it was the commonest performed bariatric surgery in the United States. Recently, within the last 3 years, there is a drop in the sleeve gastrectomy, and a main reason could be understood after Jack Impens reported 43% failure rate of the sleeve gastrectomy after 6 years. If you're looking at the gastric bypass, you can see that the gastric bypass is performed in almost 50 to 60% of the bariatric procedures in the United States. And it is stable. This is the procedure which has been stable all the time. Before 2013, it was the commonest performed surgical procedure worldwide. The band procedure, as what I have already mentioned, is vanishing, not only in the United States, but worldwide. The biliopancreatic diversion and the duodenal switch is done for just limited indications for super morbid obese patients and as revisional surgery. Later on, I will talk about the omega loop gastric bypass, which is the mini gastric bypass. Obesity, as mentioned previously, is measured by the body mass index. This is the group of patients that we are interested in because they have a complete list of comorbidities. This comorbidity will shorten their life. The chance of dying, if you have a body mass index of 40, is 2.5 more than the regular person. It is a life-shortening disease. This is well confirmed and well known. How can we treat obesity? Behavioral changes, diet, sport, psychotherapy. medical treatment, all the medications that have been mentioned previously, endoscopic ballooning, and surgical treatment. All the previous treatments before surgery are ineffective in a morbidly obese patient. The perfect procedure that you can perform should be able in inducing and maintaining weight loss. It should be able in inducing and maintaining more than 50% of your excess body weight with acceptable morbidity and significant resolution of the comorbidities. The indications forwarded by the National Institute of Health in 1991 is a body mass index of more than 40 or more than 35 with comorbidities. It is a joint effort. Now, I have already underestimated the effect of diet and every other thing in doing a significant reduction in the body weight in the morbidly obese. But it is very important in conjunction with surgery and after surgery. It's a teamwork. You should follow your patient as a team and not as a surgeon. Dietitian, endocrinologist, psychotherapy should continue after surgery. Otherwise, you will decrease the success rate of your bariatric surgery. This consensus statement has been provided in 1991. Surgical treatment is medically proven because it is the only proven method of achieving long-term weight loss for the morbidly obese patients. Now, if we consider 5% worldwide morbid obesity, then we have 400 million morbidly obese persons all over the world. We are just doing 400,000 surgeries worldwide yearly, meaning we are operating on 1% of the worldwide population of the morbid obesity. The second thing, there is now excellence in bariatric surgery. The morbidity and the mortality in bariatric surgery are much, much less than used to be previously. And I think that there is always a risk in bariatric surgery that every mortality in bariatric surgery will be reported in every newspaper and in every television. Because if a patient has hemicolectomy for a right colonic cancer and he dies, nobody is going to report him. But if an 18-year-old female had bariatric surgery, even if she has a body mass index of 50 and she dies, then it will be reported worldwide. This was a weapon of two directions. I think this improved the surgical perfection of bariatric surgeons. Bariatric surgeons are very much afraid of mortalities. Very much afraid of mortalities because it will appear everywhere. Everybody will know of a mortality if it happens in bariatric surgery. So this, I think, is the main reason, including all the other advancement in technologies, that has decreased the mortality in bariatric surgery. Now, combined with, we are not treating a large percentage of the patients which are morbidly obese, probably due to the restrictions, the strict restrictions of the insurance, the caregivers, the Ministry of Health. So not every patient with morbid obesity is afforded surgery. The American Society of Metabolic and Bariatric Surgery and the International Federation of Surgery for Obesity, in their meeting a few months ago, put forward new guidelines for obesity surgery. They decreased the body mass index as a sole indication for bariatric surgery to 35. Now you can perform bariatric surgery for any patient who has a body mass index of more than 35. They also said that metabolic and bariatric surgery should be considered for individuals with metabolic disease and a body mass index of 30 to 35. This is not a new thing. Already in 2016, the American Diabetic Association issued a joint statement that metabolic surgery should be considered for type 2 diabetic patients who have a body mass index between 30 and 35. These are the surgical procedures we do today, excluding the middle ones. The first are restrictive procedures, restricting the amount of the food or the calorie intake that patients take. Malabsorptive procedures, the one that I have already mentioned, they have only specific indications and they are done in a very, very limited number of patients. And the last is mixed procedures, the long limb Roux-en-Y gastric bypass and a mini gastric bypass. Okay. Now, there are a lot of factors included in obesity. Hormones, factors that affect our appetite and food intake. The most important is ghrelin, which is appetite-inducing and increasing, and the GLB-1 and the BYY, which block the appetite. These are the procedures we do today: sleeve gastrectomy, gastric bypass, and mini gastric bypass. Now, I will talk about mini gastric bypass. Again, okay. Now, mini gastric bypass was introduced in 1997. No surgical procedure has actually divided the surgical community more than did mini gastric bypass. Opponents for mini gastric bypass say that mini gastric bypass has a significant risk of bile reflux, necessitating reversal, and a higher risk of carcinoma of the pouch. These have proved to be wrong. The bile reflux in this form of the pouch and this form of the anastomosis is very minimal. The bile, when it reaches after 2 meters, the anastomosis, it will be diluted. So even if there is reflux, it will not affect it. And there has been no single report of carcinoma in the pouch. One single report of a carcinoma of the remnant, which is not related to surgery, actually. Just, I will conclude. Yes. I will conclude. Okay. The takeaway message from this. This is a classical metabolic syndrome patient. Metabolic syndrome is a constellation of factors that increase the cardiovascular accident risk. It includes hyperglycemia and insulin-resistant visceral obesity as central to the definition of the metabolic syndrome, additional to dyslipidemia and hypertension. This is the classical patient. He has abdominal obesity. He has blood sugar measurement, blood pressure measurement, and tablets. You can see the tablets that he's taking. He's taking 10 tablets per day. The only chance for such a patient to go back to normal and leave all these things is gastric bypass. So if you have a patient with metabolic syndrome, his only chance of going back to normal is gastric bypass. Everything else is bullshit.
دكتور نعمل بس ديسكشن تمام؟ خلينا بانل ديسكشن اخر شيء. كل المحاضرين اذا في اسئله كم سؤال سؤالين وبعدها ناخذ الصوره الجماعيه. فرجاء كل المحاضرين دكتور رامي، دكتور معتز، دكتور رائد، اذا في اسئله. فهلا دكتور عبد الله.
في غير الميكروفون هذا؟
أول شيء شكرا كثير للمحاضرين. سؤالي للدكتور رائد والدكتور بدرية. دكتور بدرية سامعنا؟ في سؤال لك وللدكتور رائد. في عيادتي في جراحة الأوعية الدموية بلاحظ إنه اللي عندهم chronic venous hypertension in the lower limb characterized by having dense fat in their body مش soft fat in their body. بالعربي بكونوا سمان بس الدهن تبعهم كنز يابس، بتفكروا مصل يعني. ولذلك بشوف الحالات هاي أكثر في الرجال عن النساء. أنتوا في عيادتكم بتلاحظوا هالقصة هاي كمان ولا بس أنا اللي ملاحظها؟ هذا سؤال. السؤال الثاني، أحسن عبارة سمعتها obesity is a chronic relapsing disease. فعلا هاي، وحتى بعد العمليات it's a chronic relapsing disease، فلازم نتذكرها كويس.
I call it the Hulk syndrome. There are particular patients who come to the clinic which do not have central obesity, do not have the apple-shaped obesity, but they have thick legs and thick bodies, which is continuous. I noticed that also in the clinics. They have a high incidence of chronic venous insufficiency. It is reported, I think.
يعني and I agree with you لأنه as a diabetologist or endocrinologist احنا بنشوف ال patients with long-standing diabetes, they have apple obesity, but because of the diabetic neuropathy, they lose the fat, and you see that they are like a ball, and بالإجرين بتلاقيهم رفاع كتير. And this is one of the complications that we see in our clinic in patients with long-standing diabetes and diabetic or severe proliferative neuropathy. And this is right.
في أسئلة؟ أنا بدي أسأل صراحة.
تفضل.
أنا سؤالي دكتور رائد وفي دكتور حكيم حكى هنا إنه الأوبستي is a chronic relapsing disease. What's a new terminology is arising is what is about metabolically healthy obese person. يعني ممكن يكون حدا obese لكن ممكن يكون metabolically تمام he's healthy.
اوكي يعني شفنا كثير بالاور كلينيك انه you have a patient عمره 80 or 85 years. He is fat, morbid obesity, body mass index over 40, with still without complications. This could be a genetic environment, but يعني it doesn't mean, but they are little. So most of the patients with obesity, unfortunately, the expectancy of life is less. The higher body mass index, the expectancy of life is less, and they die early because of the complication, mainly cardiovascular and hyperlipidemia.
والsecond question لدكتور تفضل.
Yes. Abdominal obesity is always bad. Okay, if you have hip obesity, then it can be healthy.
Yes.
You know why? Because you have at least 4 to 5 kilograms in your belly.
السؤال الثاني لدكتور عبد السلام تمام لأنه في دكتور أمين حكى عن علاقة الأوبستي في البيدياتريك وتحول الفات سيلز والسايز اوف ذا فات سيلز. هل في علاقة ما بين الايرلي اوبستي تمام أو الدايت في البيدياتريكس والليتر اون الكونسيكونس اوف اوبستي ان فيوتشر لايف؟ هذا السؤال الأول. السؤال الثاني هل في علاقة ما بين لأنه عم نحكي عن الانتيبيوتيك والانتيبيوتيك ابيوز، هل في علاقة ما بين اليوزنج اوف برود سبيكترم انتيبيوتيك والاوبستي؟
Okay, regarding first question, بالنسبة إنه 25 to 30% of these obese children will be obese adults. لأنه cells when they multiply or during early infancy or childhood, this will mean that most probably will have an obese adults. In addition to the family history of parents, one of the parents, if they are obese, this will increase the incidence of having obese adult. Also, as I have said, you have to concentrate in the 1000 day حكينا antenatally, early in life, breast milk, healthy food, physical activity. This will decrease the activity. Regarding your second question, I think has been no report about the use of antibiotics and the increased incidence of obesity.
Dr. Abed, I see in my clinic sometimes they brought children يعني around 12 or 14 years, and he is obese, and you see the color pigmentation on the neck. These patients, they are future diabetic patients, and they have the acanthosis nigricans, and this is why we should look at it for each child, because this is future diabetic patients, obese, that will pass على diabetes. وانت حتشوف انه you see that all the family are obese, nobody run in the family. It's not only genetic, but nobody run in the family. Well, obesity is familial. دكتور طارس بده يعطي كومنت لو سمحتوا.
لعل المضبوط عرفنا الاوبيسيتي وعرفنا انه ديزيز، لكن احنا كمجمع اطباء لازم نفكر على نطاق وطن انه اوبيسيتي هو بيردن على الببليك هيلث سيرفيسز. انا بفكر من هذا المؤتمر نقدر نطلع بنتيجه انه لازم تو فايت اوبيسيتي زي ما احنا تو فايت دايابيتس، بس الاوبيسيتي هي المصدر. فانا اللي بقوله انه نقابتنا مع اللجنه العلميه مع ستيك هولدرز مينستري اوف هيلث لازم نعمل كامبين بحيث إنه نقدر نمنع الأوبيسيتي من الصغر. هذه دائما الوصايا اللي لازم، ونستغل ب4-3 زي ما حكيت إنه في عنا الورد اوبيسيتي داي، هذا كل سنة بنعمل. خلينا نعمل كامبين حتى نقدر نزيد الاويرنس بمجتمعنا، ومن البداية نبدأ بأكل صحي للتشايلد هود وللأدلت. وهذا أنا توصياتي مضبوط لعبد السلام باللجنة العلمية وبالنقابة والدكتور سفيان والنقابة إجماعاً واللي بيشتغلوا بالصحة. يعني أنا بفكر يتبناها كمان Ministry of Health يكونوا على أهمية الاستعداد. شكراً.
بس بدي أعلق على كلمة الدكتور بشير. أي نعم بدنا ستيك هولدرز وتكون في عنا اوبيزيتي داي ونرفع الأويرنس ونحكي في المدارس وكله، بس نبدأ بأنفسنا، نشيل كل الاكسترا كالوريز، الكولا والاكس ال والعصير وكل اللي بتشتريه كلنا، ونبلش بانفسنا نخفف السكرين تايم ونكريز الفيزيكال اكتيفيتي. احنا اباء ودكاتره وقائدين رياديين في المجتمع، اذا بلشنا من انفسنا ما راح نبلش وزاره الصحه تحكي على المدارس ونحط هيلثي فود ونعطي اولادنا سلطه. اذا انا بدي اعطي اولادي شوكولاته وكولا واكس ال كل يوم واحطه على الشاشه يحضر زي ما بده.
دكتور وائل، بلاش العشاء اليوم. دكتور وائل، دكتور وائل،
خلاص حكيت.
دكتور وائل،
دكتور بشير اقعد، حكيت بما فيه الكفايه. لا مضبوط حكيت. اول اشي شكرا كثير للمنظمين وللمحاضرين، وشكر خاص يعني للدكتور عبد السلام والدكتور سفيان اللي هم ديناموهات النقابه يعني، ويستحقوا منا كل شكر. الشغله الثانيه، قبل يومين كان اليوم العالمي للغه العربيه، واحتفل به في كل العالم بما فيها الجمعية العامة للأمم المتحدة. فيا ريت يعني المحاضرات باللغة الإنجليزية مش مشكلة، بس النقاش بيننا وبين بعض يكون بالعربي على القليلة. لو زرقت لك كلمة إنجليزي هون كلمة إنجليزي هناك مش مشكلة. يعني مجرد لفت انتباه. وأنا دائما من المطالبين بتعريب المحاضرات في الطب. الشغله الثالثه سؤالي للدكتور عبد الله، لانه انا ما الي اسال لا على الاوبيزيتي ولا على السكري، ويمكن ما حداش ساله. لا الدكتور عبد الله من الناس الاكسبرتس في الموضوع يعني، واللي عندهم تجربه كبيره. واحنا از يورولوجيست يعني مش كلنا بنشتغل في الالكترال ديسفانكشن، بما فيهم انا يعني ما بحبها الا اذا في عمليات. بس في هلا طالعه موضه جديده ودعايات ومش عارف ايش وموزه وبتاع عن الاوبر البلازما والشوك ويفز. شو رايك فيهم هدول؟ احنا بعطيك يعني احنا كيورولوجيست يعني لحد الان ضد هاي الشغلات ومش مقتنعين فيها. فشو رايك انت بما انك عندك هاي الخبره الكبيره؟
شوف الشوك ويفز صار لها تقريبا خلينا نقول 6-7 سنين طلعت. كان الطاقم تبعون اليورولوجي في رامبام هم اللي عملوا البحث الاول وطلعوا فيها. مش مشكله، نصابين بس انه عملوا بيبرز عليها وصاروا بروفيسورز. شو بدنا نسوي؟ اليوم موجوده في كثير محلات، يعني في كل مدينه صار في مركز للشوك ويفز. تقريبا بيعمل لك سيشن ل 6-7-8 مرات، ياخذ له 6-7 آلاف شيكل. الريزلت لحد هلا ما بشجعوش. عشان هيك احنا
انا عبد الله انا لحد الان ما شفتش ولا واحد استفاد من الشوك ويف.
شوف بدك واحد يكون عنده لسه يعني تقدر تعمل له نيو فاسكولاريزاتيا كويس، يعني واحد انه بجوز كان عنده سايكوجينيك حتى بس عملوا له اياها بلاتسيبو زبطت معه. بس ودي مريض سكري اللي عنده كل الاوعيه الدمويه تبعته خربانه وما فيش عنده الاستيسيتي كمان، مش راح ينفع معه. البلازما ما فيش عندي انا خبره عنها يعني، لا للاسف. في اليوم للبيروني بيستعملوا الابر هاي بس اليورولوجيست مش احنا.
I would like to ask بالعربي بدي اسال الاندوكراينولوجيست. We know that the best treatment for metabolic syndrome and type 2 diabetes is gastric bypass in a morbidly obese patients. What do you think of bariatric surgery in type 1 diabetic patients?
Type 1 diabetes, to consider bariatric surgery in obese patients, usually it's not one of the priorities if we have an obese patients, and usually we wait until the cessation of growth when they end their, and usually until if the patient is having BMI is more than 40, and he's having complications, and he's insisting, and he's have these complications, we will think of doing bariatric surgery. But as a pediatrician, or usually it is not recommended, and I have seen patients where we advise them not to do bariatric surgery, so they travel to Istanbul and they do the bariatrics. أنا هلا تذكرت أحكي بالعربي، بيسافروا على اسطنبول عشانك هاي، بيسافروا على اسطنبول بيعملوا العمليات وبيجوا عشان ممنوع يقدروا يعملوها على حساب التأمين الصحي الخاص فيهم، وبيجوا بعديها بيكملوا، أما اللي بيخلصوا البلوغ بيقدروا يعملوا هاي العملية بشكل عام، بس usually we don't advise.
بس دكتور عبد السلام، يعني تايب 1 ديابيتس هم المرضى اللي عندهم كومبليكيشنز لما بوصلوا ل 17 و 18 صار اوريدي عندهم مشاكل في الهاي. هلا هم معظمهم معظمهم هم لين بيشنتس، يعني ريرلي تشوف مريض عنده اوبيزيتي اللي بيحتاج يروح لسيرجري. موربيد اوبيزيتي،
موربيد اوبيز. بس هلا لما نحكي عن كربوهيدرات كالكوليشن وتعطيهم الفريكونسي انهم ياكلوا زي ما بدهم ويستعملوا النيو كربوهيدرات كالكوليشن والكوركشن، بيقدروا ياكلوا زي ما بدهم، فبالتالي ممكن يكون في عندك اوبيز او they have a negative, could be part of monogenic diabetes, could be part of that and could be considered for bariatric surgery.
أنا الريكومنديشن هلا هدول البيشنت they should be well controlled انك تدخل في عمليه. 14 سنه 140 كيلو تايب 1 طيب يعني اوبيز. اوكي
حسب الريكومنديشنز من وزاره الصحه هذا لازم تستخدم له ثيرابوتيك، بدك تستخدم هذا فارما. if failed then we will consider it for special recommendations to do surgery, but usually it's not allowed till now.
حكيم، اخر سؤال بس للدكتور البكري. تمام، انت حكيت تمام عن الاوبستراكتيف سليف ابنيا، بدي اعرف ايش هم الكاركترستيك كرايتيريا لبيشنت ادلت لما بنعتبره انه بيكويكيان سيندروم.
هلا البيكويكيان سيندروم هي ديفرنت من الاوبستراكتيف سليب ابنيا. البيكويكيان هي اسم قديم للاوبيزيتي هايبوفنتيليشن سيندروم، اللي هم المرضى اللي مش موضوع بس عندهم اوبستراكشن، عندهم مشكله بالهايبوفنتيليشن، فهدول المرضى بيكون عندهم كمان غير بيكون معهم كمان هايبر كابنيا، بيكون عندهم كمان ريسبيراتوري اسيدوسز. معظم البيكويكيان سيندروم عندهم او اس اي 90%، بس يعني اغلبيه الاو اس اي ما عندهم بيكويكيان سيندروم، فلا نفرق بين التنتين.
انا سالت السؤال هذا عشان الديفرنشيشن ما بين الاوبستراكتيف سليب ابنيا
هذاك موضوع ثاني. هايبوفنتيليشن وبده تريتمنت حتى مش بالسي باب، يوجوالي الريكومنديشن يكون باي ليفل فنتيليشن، ان اي في فنتيليشن، مش السي باب ثيرابي. طبعا بدهم هدول بوليسومنوغرافي ويكون مع كامبنوغرافي نقيس السي او 2. نعم صحيح.
ثانكس ا لوت.
اسمحوا لي انا ضايقتكم بالاسئله، بس اخر سؤال لإلي، اخر سؤالين. ما حدش حكى عن اللونج تيرم افكتس اوف بارياتريك سيرجري، وبالذات في بلدنا لانه المتابعه غير كامله. فانا حابب اعرف منك اذا بتتابعوا هدول الحالات ولا لا كويس، ولا بهربوا منك وبيرجعوش. الشغله الثانيه نسيتها.
تمام خلينا على شغله.
اوكي.
The figures are international. Almost 30% of the patients do not come back for follow-up. Okay, and if you call them, then they can't answer. They change their phone numbers. You could generally follow up 65 to 70% of the patients. This is the maximum that you can follow up. This is not also here, it's also outside, it's worldwide. Okay, we follow these patients, we follow their weight loss for at least 10 or 12 years. There are prospective randomized studies which followed patients for 3 to 5 years. And they found resolution or remission of their associated comorbidities in almost 90% of the cases. We know that patients who undergo gastric bypass and mini gastric bypass have persistent reduction in their weight and improvement in their comorbidities. The problem was with sleeve gastrectomy. It's also here and it's also outside. The failure rate is almost 40 to 45% over 6 years. And these are mostly sweet eaters. They are mostly sweet eaters. So we follow the patients. And you have to follow them up. The dietitian, the psychotherapy, the group therapy, they have to be followed by everybody. Otherwise, the success rate of the operations will go down.
آخر سؤال. شكرا دكتور. آخر سؤال لاست كويستشن، بعدين الصورة الجماعية. يا جماعة حضروا حالكم. الدكتور محمد مناصرة. سؤال بسيط يا دكتور سريع.
طبعا هو أكثر يعني هو مش هو اقتراح أكثر من إنه هو السلام عليكم دكتور محمد مناصرة. هو يعني كان مجرد اقتراح أكثر من إنه سؤال. يعني إحنا صراحة كل الدكاترة على عيني وعلى راسي وعلماء وكل العلم اللي انحكى ممتاز، بس أنا يعني ما سمعتش ولا دكتور من الدكاترة اللي كانوا موجودين حكى عن بلان أو صنع قرار. وإحنا يعني في مؤتمر موجود عندنا كل صناع القرار اللي ممكن لو أعطوا طرح أو قرار لأي وزارة من الوزارات إنه يتخذوا قرار. فأول إشي أول فكرة يعني بسيطة خطرت في بالي إنه يكون عندنا خطة طويلة الأمد بموضوع الأوبيزيتي. أبسطها البادي ماس إندكس ينعمل لكل طالب في المدرسة.
والله لازم نبلش أنا وأنت يا حكيم.
أنا أول واحد.
يعني البلان بتبلش من عندي ومن عندك يا حكيم.
أنا أول واحد، أنا ما عندي مشكلة، بس هي الفكرة كلها.
شباب يعطيكم العافية. خلينا على الصورة الجماعية هسا. عشاء بعدين الحفلة هون بعد العشاء. اللي بده حاب يسهر الحفلة هون بعد العشاء. في فرقة دبكة مع أغاني بعد العشاء هون.